Visible?
Not yet, sir. Yes, sir.
Yes, sir.
Yes.
Okay. So what changes take place? This particular thing, is given in days of storage 0 to 35. You can see the pH. First change that happens is the pH, where it will be gradually going on to the acidotic phase, starting from a slightly alkaline to acidotic phase. And you can see the sodium is very high initially because of the adjuvants we mixed with that. And
Sodium.
potassium, you can see from the normal value increases to almost 6 times the value from the days increase. And the ATP value is almost half within this time. And 2,3-DPG gets very much reduced, almost negligible. And hemoglobin in the plasma, because of the lysis, also increases. So, and this picture will tell you about the changes that happen from the day 0 or the first 24 hours to up to 42 days of total storage time. So the same thing, pH, 2,3-DPG, saturation, lactate, potassium, free hemoglobin. So if you remember this picture, you can mention at least what are all the points that you have to say in the changes that is happening. And over a period of time, gradually all these things, 2,3-DPG declines, pH also goes on to the acidotic side, saturation decreases, lactate goes on increasing, potassium increases, and free hemoglobin also increases. So these are all the changes that happen. And of this, the 2,3-DPG is very, very important. What is this 2,3-DPG? What is your idea about it?
2,3-diphosphoglycerol, which is a byproduct in glycolysis.
Glycolysis, intracellular glycolysis. Okay. And what is the importance of that in RBC? This question can be asked in your practical exam. More than your theory, you should know why 2,3-DPG is very important. All of you know that when 2,3-DPG is decreased, the ODC curve gets shifted to the left, or when it is increases, it gets shifted to the right. What exactly happens? What is the relationship between hemoglobin and 2,3-DPG?
Oxygen affinity is affected.
Oxygen affinity? Why that is affinity is altered in value when the values of 2,3-DPG are changed? So see, remember this, 2,3-DPG, if the value is high, it does not allow oxygen to be bound to the heme moiety. Okay, so oxygen has to be going out of the RBC. That is called the rightward shift. That is good for the tissues. Okay. On the contrary, if the 2,3-DPG is low, it will keep the oxygen along with the hemoglobin. It will not allow the oxygen to be depleted or removed from the hemoglobin. Okay, that is the most important thing, because it binds in the place of oxygen. 2,3-DPG will be binding it. Okay, so when 2,3-DPG values are more, oxygen does not have a place to come and bind with the hemoglobin, heme moiety. So it has to move out. On the contrary, when 2,3-DPG values are low, there is enough space for oxygen to come and hit the hemoglobin or the iron moiety, and it will not move out. Okay, so decreasing 2,3-DPG, it shifts the curve to the left, will not allow the hemoglobin to go out. I mean the oxygen to go out. On the contrary, if the 2,3-DPG value is more, it will not allow the oxygen to come and get stuck to the hemoglobin, so it will be delivered to the tissue. So at the tissue level, 2,3-DPG will be more and oxygen will be released to the tissues from the capillary blood. Okay. At the lung level, because the deoxygenated hemoglobin does not has a lot of 2,3-DPG, reduced 2,3-DPG, it will bring back the carbon dioxide and take in more oxygen. Okay? So that is how the exchange is happening, and that is a very important thing that has to happen. And so initially, the 2,3-DPG, because it gets depleted after 2 weeks, the blood that you give will not be able to initially carry the hemoglobin. But how does it recover? Within what time the 2,3-DPG value will become normal?
Within 24 hours.
Within 24 hours, it will become normal and the hemoglobin will be able to carry that. That is the first important change that has to be emphasized in the changes that happen. So in the absence, it exhibits a greatly increased oxygen activity for any given partial pressure. And the levels of ATP in RBC tend to drop comparatively slowly and diminish to levels at the end of 5th week. It is the time period. And the absence of ATP promotes dysfunction of ion pumps and other membrane proteins. And this in turn results in impaired cellular mechanism, most probably the shape of the RBC. What is the normal shape of the RBC?
Biconcave.
It's a biconcave. Why it is biconcave? It's a basic physiology point.
It's
Yeah?
a Burger.
Because it does not have a nucleus. Yeah?
Nice.
RBCs do not have a nucleus. That is the reason why their shape is biconcave. And another reason for this biconcave nature is, what is the advantage of this biconcave structure of RBC
Can
in the
easily pass
microcirculation?
through.
And the transport.
It actually can elongate further and manipulate and pass through the microcirculation. The narrow vessel require the alteration in the shape of RBCs for it to navigate through the small channels in the microcirculation. Okay, so this biconcave, if you have a spherical structure and it tries to elongate, it may burst. On the contrary, a biconcave nature of the RBC, even if you stretch it further and make it longer, it will not burst or it will not lyse. And that is the way the nature has made it beautifully in such a way that it can elongate and navigate itself through the small channels of the microcirculation. And so once the ion pumps begin to fail, that is the time the erythrocyte becomes swollen and loses its biconcave shape and starts becoming spherical or hemispherical. And this decreased alteration in the space appearance or the shape decreases the flow through the microvascular circulation. And that is the reason why sometimes you can get microvascular occlusion or aggregation. And one of the reasons why we don't like to give a blood transfusion during a microvascular surgery is that this deformed RBCs can get caught in the microcirculation and spoil the result of the surgery. Okay? And stored erythrocytes reduce microvascular flow and some functional capillary density also. And there are vesiculization happening. That is, the red cell membrane, in addition to the alteration by becoming spherical and swollen, they also develop lot of vesiculization, which means small areas of cyst-like things appear, which also alters the shape and the functional nature of the red cells. And they become more fragile. That is the reason why the hemoglobin gets released, and this hemolysis releases the free hemoglobin, and this leads to the again blockage of the microcirculation. And excess free hemoglobin also suppresses the nitric oxide and the normal mechanism by which hypoxic vasodilation can happen. And this is another change which we have to mention, which will affect the perfusion of the organs. And this is where the young blood and old blood becomes very important, because if you have a freshly collected blood, that will have a more or less normal functioning RBCs up to say the first 3-4 days, and at the time it will be very useful. That is the reason why you always ask for fresh blood whenever you want a complete restoration of the microvascular circulation. And in the absence of nitric oxide mediated blood flow, hypoxic tissues may be unable to attract the flow and shock will still persist in that patient. And this accumulation of metabolic byproducts, waste products will also are noxious enough to cause serious problems. And that is the reason why we have to have a knowledge of the changes that are happening in stored blood. And so massive amount of potassium and lactate accumulate, which is extremely acidic environment, especially at the 42nd day whole blood bag. And what are the effects of accumulation of these pro-inflammatory molecules? They will upregulate the pro-inflammatory gene expression in the leukocytes of the recipient. So that will the reason why there may be reactions that happen in the patient if you give too old blood to the patient. And blood gas analysis of the stored. I am going to show this picture and you have to find out what are all the changes, especially one particular change I want to see whether any one of you can pick up. For example, this pH, all of you know, has become 6.58. That is quite acidic. And PCO2 enormously increased to 121. CO2 is drastically reduced. And electrolyte values, potassium is again drastically increased, sodium has decreased. Why there is no calcium in this at all?
Calcium has bind with citrate.
It has been bound with the citrate. Okay, so
Yes,
if you find any ABG report given to you without telling what is the source in the exam, and if you find no calcium in that, you must say this is the ABG report of stored blood. Okay, that is the reason why I am putting up this for you to identify this ABG report in the practical exam in case they are giving it to you. You should not say patient is in a severe metabolic acidosis and respiratory acidosis and hypoxia. It's a type 2 respiratory failure. This is not type 2 respiratory failure. This is a stored blood because calcium is absent. So always when the values are grossly altered, look at the calcium and you can identify whether it is stored blood or the normal ABG report. And while freezing the blood, what are the advantages that you get? You can freeze them by two methods, and you can store two important components of the blood, that is RBCs and platelets, can be stored for a number of time. The duration of storage can be enormously increased by storing it at minus 80 degrees with this preservatives that you are using. And you can see what is this dimethyl sulfoxide, that is the DMSO, which is used for cooling the technique. And the other one is the glycerol, which is used. So when you use these two, you can use them for or store them for more than a year and then reuse it by trying, just like you do it for FFP and your cryo. And the changes that take place in the platelets, they also lose their shape. So this is the normal shape of your platelets, and over a period of time you can see how they are changing. So their shear stress makes them change into this, and then their integrity is also lost, and they become degranulated. They start releasing their contents, and then they bind to the adhesive sites like protein fibrinogen, and that is how the platelet aggregate forms. So this aggregation also takes place over a period of time, and this is another important limited time frame change that you have to remember. And this once you are trying to activate, they can release all the granular content, and the expression of the sequestrated membrane phospholipids lead to again another reason for the platelet activation. And what happens if they are stored by an agitator? That is the platelet lysis happens, and enzyme called calpain, which is a protease enzyme, which is also released, and this activation of calpain causes degradation of cytoskeletal proteins like actin, and generate platelet microvesicles. So microvesicle formation leads to decrease in mean platelet volume and also contribute to procoagulant activity. So inside the intravascular thrombosis can happen when you give platelets which are agitated and given. So you have whenever you want to give platelets, these are the rules that you have to follow in this particular application. Now coming to the second part of that massive transfusion, she said what are all the definitions for that. It is better to take the definition which has a shorter period of time. And usually they say you have to replace the blood volume within 24 hours. That means you give 5 liters of blood in 24 hours or 10 units which is equivalent to each unit is 500 ml. Again you give about 5 liters. Both the definitions are more or less same. But when you say the definition, even though it is accepted for theoretical purposes, it is better to use the shorter duration definition so that you know whether the patient is responding to your therapy or not. So it is always better to use this for practical purposes, whether it is you are giving more than 4 units within 1 hour or 50% of the total volume within 3 hours. That will be better than using the 24-hour criteria. The indications are trauma-related, obstetric hemorrhage, surgery, gastrointestinal bleeding, etc. What is this ABC score and how it is useful? Are you there?
Yes, sir. No idea,
Have you
sir.
read about this? ABC, it is not airway, breathing, circulation. What is the score? Assessing whether you have to give empty. Anybody else in the audience who can answer this
No
question?
idea, sir.
Huh?
No idea, sir.
Okay.
Assessment of blood transfusion score.
Assessment of blood
ABP.
ABC score is clinically useful validated scoring system based on 4 variables. Okay. So this is a assessment of blood consumption. That is the expansion of this acronym. Assessment of blood consumption. It is based on 4 variables: the heart rate, systolic blood pressure, positive fast, and penetrating torso injury. So this is mostly useful in trauma patients. So if you have a score of 2 or more, it is an indication to activate the MTP, that is the massive transfusion protocol. So it is identifies 95% of patients requiring massive transfusion, but of course 5% there is a negative prediction also. Next, what is the massive transfusion protocol to coordinate the care of patients requiring massive blood transfusion when their bleeding is more than 30% of your total blood volume, and it helps in good communication between different service teams, the trauma team, the nursing team, the transfusion medicine, lab personnel, and it avoids delay in clinical care, lab testing, and blood products administration and nursing care. So all these things are achieved by following the so-called massive transfusion protocol. So it is nothing but a way to coordinate the care of the patients who require a lot of blood transfusion because of heavy hemorrhage. And what are the criteria to warrant the activation? ABC score of 2 or more points, persistent hemodynamic instability, or active bleeding requiring surgery or angioembolization, and blood transfusion the trauma bay itself. As soon as the patient arrives in emergency, where you find him pale like a paper, and you start the O negative as an emergency, that is again another indication to activate the massive transfusion protocol. What equipment are needed for MT? That is the large bore catheter, typically ranging from 14 gauge, which can be inserted peripherally or centrally or intraosseous. The warmer, which should be inline and or surface warmer or body warmers are also needed. Invasive arterial pressure monitoring, continuous core temperature monitoring, and there is a blood refrigerator within the resuscitation bay, which should be stocked with universal donor product. And they may have O negative PRBCs, 8 units of CROD, group AB or low titer, and B plasmas also will be available. and adequate supply of colloid and crystalloid infusion set. IV calcium preparation should be available to replace the lost calcium because of the heavy citrate content, and rapid infusion pumps and pressure bags, and adequate manpower. All these things are the requirements to start an MP. And monitoring and labs, ECG, capnometry, arterial core temperature, and thromboelastography or ROTAM, we said, has now become the in thing for bedside monitoring. Avoid wasting sending the samples to the lab. And bedside ABG is also now available, and from that you can get the electrolyte and lactates, etc. And these coagulation tests only may take a little time, and fibrinogen estimation may all take some time. You have to send them to the lab. And what is the defined ratio in MTP? How it is useful? Usually it is a combination or a ratio of RBC to FFP or cryoprecipitate and platelets. These are the three important components which are given at a particular ratio of 1:1:1 or 2:1:1, depending upon the values of hemoglobin and other things. And usually it is activated after transfusion of 4 to 10 units in an emergency. And blood banks ensure rapid and timely delivery of all the components. Once you activate the protocol, then the blood banks in major institutions which regularly practice MTP, they will all keep sending the supply until you say stop the supply. This reduces dependency on laboratory testing time, decreases the need for communication between blood bank, laboratory, and physician. The complications can say immediate problem secondary to volume resuscitation. Either it may be inadequate resuscitation or overzealous, and sometimes you may have anaphylactic reactions. Then you have dilutional coagulopathy, low colloid oncotic pressure, and problems related to transfusion of large volumes of stored blood like hyperkalemia, worsening the acidosis, lactate acidosis, all these things can happen. Citrate toxicity, hyperkalemia, hypothermia, hypomagnesemia, etc. And late complications are coagulopathy, immune hypothermia, metabolic abnormalities, and transfusion reactions, and rally also, and febrile non-hemolytic transfusion reactions. Now, what are the endpoints of successful MP are mean arterial pressure between 60 to 65, HB 79, international normalized ratio of 1.5. Fibrinogen level is very, very important indicator to make sure that there is no unnecessary bleeding, and 1.5 to 2 grams per liter. Platelet count above 50,000, and pH between 7.35 and 7.45, and temperature, core temperature of the patient should be 35 degrees. So these are all the endpoints of a successful massive transfusion. Now coming to the blood products, what are the blood products, how they are classified? They can be classified as cellular components, which include red cell concentrate, leukocyte reduced and platelets, and granulocyte apheresis. Plasma defined are FFP, single donor plasma, cryoprecipitate, cryopoor plasma, albumin, and immunoglobulins. And what made blood component therapy feasible is because of the availability of multiple plastic pack system. This is one of the major advancements in the collection of blood and separating it as soon as it is collected. So the multiple pack plastic pack system, refrigerated centrifuge, different specific gravity of the contents, which allowed them to be get separated. And what are the methods of separation of the components? Low and high speed centrifugation, gravity separation, apheresis by cell separation. What is the meaning of this apheresis, Virami?
We will remove only the platelet and other components will be returned back to the donor itself, sir.
Yeah, you first draw the whole blood from one end of one vein of the patient and pass it through a machine, select whatever component you want, and return the rest of the thing back to the patient to another insertion into the vein. Okay, so that is called apheresis. I'll show you the pictures there. However, the donor selected how much blood is taken. So they are chosen about without, they should not have any infection or other contaminations, and that the donation should not harm the donor. That is also very, very important. Not only should not be harmful to the recipient, it should not harm the donor also. And normally 450 to 500, but in our setup they take only about 350 to 400. With Western standard they take this much. And CRBC is separated by collecting the whole blood, then store it at 2 to 6 degrees till it is processed. And plastic bags are kept in the buckets of refrigerated centrifuge and balanced. And then heavy spin of 5000 G. This is what I told you. The unit of the spinning is 5000 G for 5 minutes at 2 to 6 degrees centigrade. Then you will get the supernatant plasma, and the cells will settle down. We can separate them. The other types are microaggregate free irradiated red blood cells and leukocyte depleted red cells to prevent the unnecessary reaction through these white cells which can happen. And the steps in the production of this thing, this is a flow diagram which shows how to do that. Whole blood is centrifuged to filter remove the leukocytes, then that will get you the packed red blood cells. And the platelet, what are the supernatant fluid will be the platelet rich plasma. And again, this is fun to remove the full platelets, and then the supernatant plasma will be immediately frozen to get you the fresh frozen plasma. This should be done within 6 hours at the minus 30 degrees temperature. And once you thaw that, it gets the precipitate. And from this plasma, which after removing the precipitate, you can get the supernatant fluid, which will collect all the protein components like albumin, immunoglobulin, and coagulation factors. And the features of red blood cells are, you must also say how much volume for each of the components is there, what is the hematocrit, what is the pH, and how much of leukocytes is permitted. And the preparation of the platelets or it can be two platelets or a single donor platelets, and they require usually not cross match, but it is better to have a vivo specific platelet. Shelf life is only about 3 to 5 days. It's stored at room temperature, and it has a pH of 6.2 to 7.8. And the most important complication of platelet transfusion is bacterial infection, especially if you use platelets which are more than 3 days old. And the indications, let's see. So this is the steps in seeing the preparation of FFP. So collect it in a triple pack system, store at 4 degrees, and place the bag, and again centrifuge at 5000 G, and express the plasma in the satellite bag, and label the plasma bag and rapidly freeze them for within 6 to 8 hours at minus 70 degrees, and store it at minus 30, and it can be stored for up to 1 year. Tie it in the plasma defroster or a microwave, and place it in a plastic wrap and put it at 37 circulating warm bath to get the FFP ready for use. The features are the volume of FFP is about 1800 to 200 ml. And, it has a fibrinogen of more than 300 milligram. Cryoprecipitate is nothing but the third portion of FFP, and it contains more of factor VIII and von Willebrand factor. And
Your voice is not audible, sir.
I'm not speaking now. Is it heard now?
Yes, sir.
You can hear me?
Yeah, yes, sir.
So, the mouse has suddenly lost its So 10 prepared units of usually the cryo is issued as 10 prepared units of cryoprecipitate because the volume is very low. As I said, it is only about 10 to 20. You require 10 to 10 prepared units, which will have about 200 to 400 ml minimum in a pooled bag. Applications are they are prepared the granulocyte. As you rightly said, it is for neutropenic cancer patients who are unresponsive to antibiotics. If they are suffering from life-threatening infections, and it's prepared by separating the blood cells from people who are donated by volunteers whose leukocyte count has been, you can increase the leukocyte count by pre-treatment with corticosteroids, or those with chronic granular leukemia patients. Even though they are suffering from leukemia, they can be a donor for donating granulocytes to needy people. And this must be cross-matched because they contain large number of red blood cells and can be stored only for 24 hours at 20 to 24 degrees centigrade. Okay, this is the point about granulocytes which you have to take. The indications for use of FFP, this is sometimes asked as a short note by itself. So fresh frozen plasma indicated for deficiency of coagulation factor, or it is also for planned surgery with invasive procedure, or reversal of warfarin in the presence of active bleeding, or thrombotic thrombocytopenic purpura, and the congenital factor deficiency with no alternative therapy, trauma patients requiring massive transfusion, warfarin-related intracranial hemorrhages, and conditions that cause deficiency of multiple coagulation factors. All these things are the indications, but FFP should not be used as a volume replacement. That is a very important thing. Even though it can increase the blood volume as a just like a colloid, but that should not be used as a volume replacement. And ABO compatibility is very, very important. The contraindications for use of FFP are is corrected more effectively with specific therapy, and when with the reversal of anticoagulation induced by heparin, direct thrombin, or direct factor is not also to be used corrected with FFP. And plasma derived components, human albumin, they are cellular material. When coagulation factors have been removed, you get mostly the albumin. That is, after the cryoprecipitate is again spun, you get the coagulation factors removed, and what remains is the mostly albumin. It is available as 4.5% and 20%, and it is heat treated to kill viruses. It has a shelf life of 2 years, and it can be stored at room temperature. And it is used to for restoring the circulating volume as one of the best colloid solution to restore the blood volume in any situation, especially in ascitic tapping. Then after that, if you want to improve the circulating volume, this is the first drug of choice. And immunoglobulins are used as a replacement in immunodeficiency people or for immunomodulation, which is called normal globulin. And there are hyperimmune immunoglobulins used for passive immunization like hepatitis B, Rh antigen, and herpes virus, etc. Other coagulation factors that are used, which are all the components of blood, are recombinant factor 8 and factor 9, mostly used for hemophilia. And you have a composition of factor 2, 7, 9, and 10, which is also called prothrombin complex concentrate, which is more specific for deficiency of these factors. And main indications for these are warfarin overdose, where there is a contraindication to use or contraindication to use FFP. You can use the prothrombin complex concentrate. This is the diagrammatic representation. This is what is called the multi-pack system. So in the first pack, you can see the whole blood is collected here, and then you centrifuge, and then the superficial plasma is removed, and the RBC will be taken at the last point. And like that, you can centrifuge at each stage, and then you can remove that. Once the achieved component is removed, and that particular type bag alone can be fused and sealed, and we can remove that. So this is what is called the multiple pack system used for separating the various components in the modern blood bank. And this is the apheresis technique. That is, you draw the blood, blood donor is collected, components separated, then the target finished products are removed, and then the remaining components are transfused back into the patient. So that is what is called the apheresis. So that will need to be answered on the discussion. So whatever points that have been left out in your preparations, you can add from this and then complete your answer. Okay.
Yes, sir.
Okay.